So with that, we're going to get started as soon as I figure out how to make my slides go. Okay. So, all right. So, and just by the way, I wanted to just say we are trying to put together some future resources. You know, the rules around telehealth are different in different spaces, and so we're working on some additional programs and additional resources, and look forward to sharing that in the coming later today and in the coming days. So what I wanted to cover today is the following. I wanted to just give some introductory comments about the moment in time where we find ourselves and how I want to encourage people to think about it. A few disclaimers. I want to talk about where behavioral health, mental health, substance use disorder treatment fit in the current COVID-19 world, how much has changed in the short term for telehealth. And then I think it's very important still to go through some key telehealth definitions and concepts that need to be operationalized to ensure that even in this time where so much has been liberalized, that organ providers are doing things the right way so that providers get paid for them, and we don't have problems that come later. And finally, I want to go into some specific reimbursement issues. I want to say up front, there are a lot of billing and coding questions that came up on our last presentation, and while I'm happy to take questions, a lot of the detailed coding questions are not going to be necessarily appropriate, although I do have some very specific information on use of modifiers, which has been a source of confusion and common reasons for denials to focus on.
And I've already gotten a couple questions in the Q&A about codes. So I just replied in the chat that should be payer specific. So just make sure to get that in writing from your payer about which codes are being approved.
By the way, thanks, Sarah. I was going to say, if you see questions, because I'm not looking at the questions while I'm presenting, but if you see questions that you think are pertinent, feel free to stop me.
Sure.
So, all right. So just a couple quick disclaimers. I always feel obligated to say this is intended to be informational. It's not legal advice. Simply by listening to this webinar. My goal today is to ensure that as many behavioral health providers as possible understand how to navigate the particularities of telehealth compliance. I'm going to use some California-centric examples on services. There are significant variations state to state, and particularly, just to underscore what Sarah just said, plan to plan. It's very important to understand the state-specific rules and the plan-specific rules. So I wanted to just start with kind of an introductory comment before we get into the telehealth of a question that keeps coming up. I've been getting this from two different sides. The question is, where do behavioral health services fit in this period of a lockdown, shelter in place, travel and work restrictions for COVID-19? So one of the things we're seeing is that although there is not uniformity in the different public health orders being issued from state to state and cities and county and federally, even though we're seeing a lot of missing definitions and a lack of clarity, there's no question that mental health, substance use disorder treatment, and all behavioral health services are very squarely considered to be healthcare operations. There seems to be in many of the public health orders a clear intention to stop or to pause elective care, meaning things that are voluntary, but there's no suggestion that mental health or behavioral health is anyway not a necessary healthcare service. Another place in which this has been coming up is some companies have been asking whether what about the definition of healthcare workers in the Family First Coronavirus Response Act, and whether behavioral health employees are workers there. Here too, same answer. The law is very vague, but I think the safest approach is to assume that anybody working for a mental health, addiction treatment, or other behavioral health company will be deemed a healthcare worker, and so not covered by the leave protection. All right, so I wanted to offer some introductory thoughts about where we are. We're at a watershed moment in the challenges facing all of healthcare, but it's particularly behavioral health. Clients, patients, and staff are canceling and refusing to come into programs, outpatient programs that we're running, or for professional services because they're sheltering in place. And there's been intense pressure to convert to telehealth. And I'm going to talk, by the way, about the residential and inpatient settings where it's a different issue. but this is still intense pressure for telehealth. We've had physicians doing behavioral health services in hospitals who have been asking questions about their right to remain at home and have communicate via telehealth with patients through nurse cooperation. So we're seeing that an enormous and unprecedented liberalization of all the rules by both government and health plans to make telehealth more successful. And so my most important takeaway from this webinar today at a high level is, in the short term, the critical thing that I want to urge providers to focus on is ensuring that in the conversion of the service from an in-person service to telehealth, that you're doing all the things that you need to do to be reimbursed. There are a lot of places to make mistakes in the billing, in the documentation, and there's a whole bunch of issues that we'll cover today. The other issue that sometimes comes up in some parts of behavioral health are the clinical safety issues. And can you meet standard of care? Are there risk issues that are unique to telehealth? And I want to talk a little bit about that. I also want to raise a more long-term issue. Even though we're in a very different environment, in the long term, one of the things that I always sort of principles that I see, and I take no joy in sharing this, it's just the reality of, is that every time a new reimbursement opportunity opens up in healthcare, a year later, it's a fraud and abuse issue. And so today, the gateway opening today with the plan after plan promising reimbursement, I can tell you, I've already heard from people at a high level in several plans, is coming with a concern that while these changes are being made out of necessity, there's a concern on the part of plans that there's going to be an explosive amount of claim growth, and inevitably some of it will be abusive. And so part of what you need to be focusing on is how to make sure that you stand out from that, and that you are doing the things as a provider that you need to do to make sure that you are standing clear as a provider who's doing things appropriately. And I also think, the opening to telehealth that is happening in this crisis will be long-term, but over time, it will be more and more important to understand the sort of core compliance issues we'll talk about. So my goal today was really to cover sort of 5 different areas. One was mental health professional services. For anybody who's listening, who's an MFT, LCSW, any kind of mental health professional, to provide some guidance. I've had a lot of conversations in the last couple of weeks with outpatient programs and also with MAT providers. These are all areas at the bottom, as I noted, where it's possible to go entirely to a telehealth mode. That is to have no more in-person service. On the right side of the column, I have residential programs and inpatient hospital settings. These are places where the use of telehealth is different, because obviously a residential program requires some staffing, and there's a limit to what can be done by telehealth. So too, in inpatient settings, it's a very interesting thing. It's really unprecedented to see an opening to telehealth, but we are, for a patient who's in a hospital bed, for example, but we're seeing partial opportunities to use telehealth. So this is what I was trying to cover today. So the first question that I think you always have to ask with telehealth is, which services translate effectively to telehealth? The first question that every provider needs to ask is, can you deliver the critical services you need to deliver in a remote modality? And we'll talk more about it, but I'm talking in this teleconference about what we call synchronous or live video audio conferencing. And the fundamental question that comes down to the bottom line question in every telehealth service is, can you meet the standard of care to perform that procedure? Is there data that you need that you don't have, right? If, for example, in many medical services, you may need lab tests, you may need a blood pressure reading, but with behavioral health services, there's a lot more opportunity to meet standard of care through telehealth. And can you assess the effectiveness of treatment? In some sectors, there are issues of safety. Are there particular issues with this patient that require some kind of immediate presence or staffing, or is that an issue that's addressable otherwise? Another question that comes up that I want to talk about is, can you mix telehealth and in-person services in residential and inpatient settings? Are prescribing rules for medication-assisted treatment or other prescribed medications relaxed to eliminate in-person requirements? And what do you do with patients whose plans don't include a home-based behavioral health telehealth benefit. These are some of the issues I want to talk about today. So in general, the ordinary, on the left side of this page, I listed kind of the main questions that we normally ask when it comes to considering a new telehealth service are, first and foremost, can you meet the standard of care for this particular service via telehealth? That's always the first question. And then the second question that as a healthcare lawyer, we always look at is, okay, what licenses do we need? Does the person who's providing the service need? Does the program or facility need to provide a service by telehealth? And then finally, that's the end of the equation if you're in a cash pay environment. If you're providing a service for insurance reimbursement, the question is, can you secure a plan contract, or are you operating under a plan, an in-network plan contract that includes telehealth coverage? I'm going to talk more about this later, but out-of-network telehealth billing in behavioral health has been extremely limited historically. So now I want to shift over to the right side of the page, because the questions you need to be asking in this crisis are, and we'll talk about these, has the government, government agency authorized at the federal level or in the state authorized a particular use of telehealth? Has a particular plan, a payer authorized coverage of telehealth? And then the last question on this right side of the page is for people in residential settings and particularly in hospitals. Is the facility going to permit delivery via telehealth? And I'll share with you, we've had several examples where a doctor in a hospital setting wanted to use telehealth, brought a device like an iPhone with an application on it to have a secure visit with a patient, but the hospital said no. That was a case where the government has said the service was okay. The plan of the patients would approve it, but the peer review body of the hospital overrode the issue. So those are the questions that need to be asked. So, the question that comes up in behavioral health, in some parts of behavioral health that need to be asked are, is this person appropriate for telehealth? And the issues that come up in different places in behavioral health are, does this patient have the organizational and cognitive capacity to participate in telehealth? Telehealth requires a much more active and cooperative role in the treatment process relative to in-person treatment for a patient, right? It requires somebody to be incredibly focused and communicative across a platform that's much more difficult. So that may be a limiting factor. Another issue that comes up, and this can be navigated, but it's a question for providers to ask, is can we meet client expectations, reasonable client expectations? And this has to, in this area, I'm thinking particularly of a subset of patients who need frequent contact, who and may or may not be able to get their needs met in a telehealth remote treatment model. And what we're finding is that providers can address this by managing expectations of what kind of contact there will be between telehealth sessions, how frequently will happen, what the response time will happen, but that's another issue. And then finally, and this may be the most serious issue, for anyone who's working with high risk patients, the risk, how do you deal with the risk of emergencies, right? The risk of potential client self-harm or a need for hospitalization is very, very different in telehealth context, right? The same level of supervision, staffing, support that might be available with an in-person encounter is very different, and these require much more advanced thought and planning. Okay, I wanted to just talk about where we're seeing behavioral health fit in a COVID-19 world. So this was going to the point that I made earlier about the fact that if you are traveling in an area where there is a travel restriction or work restriction, we are recommending that providers document and self-certify that any staff who are traveling are verified to be working for healthcare operations. We are concerned that this is going to be a bigger issue with more enforcement to reduce travel. We think it's critical to, and by the way, we've recommended, for example, self-certification can include creating your own photographic ID to identify who a person is and that they are associated with a particular healthcare, vital healthcare operation. It's critical to think about what's the minimum personnel that is necessary for your operations in a centralized place. We are having some programs that are choosing to have staff come and deliver telehealth from centralized offices, and we'll talk about that issue, and to have safety protocols for anything that's still happening in person. So some of the changes that have happened in the last couple of weeks are truly breathtaking. Last week we saw the Medicare system, CMS, expand telehealth for all services to take off the restrictions. Previously, telehealth had been very narrowly available for people in rural areas. Perhaps the biggest single change we saw at the federal level was CMS stating that HIPAA enforcement, that is health data, privacy, and security enforcement against violations, is going to be waived throughout this crisis if a provider is acting in good faith, right? And so that is in itself is probably the most, for me, the most staggering change. Relevant to certain areas of behavioral health, we've seen the DEA relax the Ryan Hate Act requirement last week the requirement since 2008 has been an initial in-person exam must occur before any controlled substances are prescribed. That has been relaxed to allow for initial prescribing subject to an appropriate exam across telehealth and prescribing in that manner. Likewise, we've seen relaxation by the states, by the Substance Abuse Mental Health Service Administration of new procedures for greater flexibility in all forms of MAT. And then at the plan level, we've seen plans issuing new policies, new codes, new guidance. And what we've seen, most interestingly, is we've seen plans go from selectively approving telehealth and really focusing on was it truly necessary or was it, and really being disapproving of telehealth just as a convenience, to an approach of global approval in this crisis. By the way, the question of how long the crisis is going to last is an interesting one. We're seeing in general, there are exceptions, but a lot of plans are describing the changes as being in effect through as long as there's a national emergency in place. Others have picked a fixed date, in some cases May 31, and you should check the date on any plan that you're as to when their policies end. All right, so I want to dive into kind of core telehealth concepts. So the first question that comes up in every state is who is allowed to deliver services by telehealth? In general, the requirement is there's a definition in the state, and in general, the states require a licensure in the state to provide telehealth. There are some states that are more restrictive on these. There are many states that have allowed for certifications from national organizations to be treated the same as licensure. And in this crisis, this rule is being relaxed. So what we're seeing is that this is not a problem in the short term, but in the long term, it's important to remember that there are definitions of who's actually permitted to provide services through telehealth. I mentioned before today we're talking about synchronous telehealth. Synchronous telehealth means real time. The doctor or the provider, the health professional, and the patient are online at the same time, and they have interactive audio and video. They can hear and see each other across the computer as if they were in the same room. There are different kinds of telehealth, and there are, for example, there are forms of telehealth, asynchronous forms of telehealth, where people message back and forth or exchange data. For behavioral health purposes today, we're talking about a live video conferencing, although one of the things we are seeing from both a number of state Medicaid plans and some private payers is that in the absence of video in emergency situations, clients are being allowed to use telephone. This may be problematic for billing with regard to most of the big behavioral health payers, but in the Medicaid context particularly, we're seeing that there's an issue that some Medicaid enrollees do not actually have the technology necessary for synchronous, which would be a smartphone at least, or a tablet, or a computer. So we're seeing an exceptional approach, but again, this is another important telehealth concept just to keep in mind. Okay, very important, the location of the provider and the patient. So we use two terms in telehealth, the distance site and the originating site. The distance site is where the provider is located. The originating site is where the patient is located. And so there are no restrictions that I'm aware of where the provider may be. There were such restrictions in the law, but these are largely have gone away in the last 10, 15 years. But basically the provider can, the professional delivering the service can be pretty much anywhere during the telehealth service. I'll talk about other restrictions about being in a private place and a secure connection, but there's no requirement that a provider be in an office location. There has been much more restriction over the years of the originating site. That is where the patient's located. This has been a concern under many states' laws. We've seen a real movement across the states of which states still restrict this. There are 29 states that over the last decade or so have removed the limitations and said the patient can be anywhere during the telehealth encounter. There are still 21 states that specify that the patient has to be in a particular place to receive telehealth, a recognized telehealth center. There are 12 states that recognize that of these 21 that say that the patient's home or a school is an appropriate place. But basically, this has been a historic limitation on telehealth. Again, we expect really significant liberalization during the crisis, but a very important rule to pay attention to if you're in one of those states. All right, so I wanted to just go through some other core telehealth assumptions to be keeping in mind. One is that the standard of care for whatever treatment you're giving is considered to be exactly the same in a telehealth service delivery as in person. That's the standard that licensing agencies apply. That's the standard that health plans will expect to be satisfied. The second is that the communication must be secure. Now we're seeing an incredible liberalization on this by both the government and the plans. I mentioned the relaxation of the HIPAA, of HIPAA against HIPAA violations. And we're seeing that there has been a rejection of some platforms that are obviously not secure, TikTok and Facebook, but there has been a broad acceptance of mainstream platforms that historically were not considered HIPAA compliant. We've seen Zoom and Skype, for example, be accepted. I know that one plan was considering limiting, one of the big health plans was considering Skype for Business because it had better security restrictions, although ultimately released a guidance that Skype itself works. Again, as I mentioned, the health plans historically limited telehealth to places where it was necessary, but we're seeing, and we're concerned about it being merely a convenience. That was a negative thing, but that's, we're seeing that lifted. To the extent possible, pre-authorization is highly advisable. It's not universally required. And finally, one of the things that's consistent across telehealth guidelines is there should be mechanisms for client feedback to ensure that clients are getting effective treatment by telehealth. So
Harry,
a few other...
Harry, where can folks find state-by-state guidelines for the originating site?
Oh, thank you. So Sarah, I know you had them on the BHCOE site, but I'm a big fan of CCHIT, the Connected Care Health Information. If you Google CCHIT 50 state telehealth, you'll pull up their most recent guide from the fall of 2019. You want to use fairly recent resources, and that's the most available free resource that's available on the internet. So I encourage people to use CCHIT. Thank you.
Great. And then a couple questions just about HIPAA compliance. If you can use telephone for individual sessions or Facebook Messenger if your county has approved it.
So if you have a specific approval for Facebook Messenger, you could use it. I would generally, if you do not have a specific approval, I would strongly advise against it because we see so much negative commentary, but that's but if you have a specific approval, then there's no reason not to use it. And again, telephone, historically, the plans would object to telephone, not being a form of telehealth, not being a permissible form. In fact, many states had laws that specifically said telephone is not telehealth, email is not telehealth. They were very worried that providers would do that. If you have a specific approval from the plan that you're dealing with to use telephone or to use a particular platform, then you can feel free to do so. So, so I want to talk about informed consent. Informed consent is a specific issue that comes up in telehealth. There are about 20 states. There used to be a broader requirement, but this is a rule that's kind of slowly rolling back. But there are still about 20 states that require a patient to give specific informed consent to telehealth being used for their treatment and being documented. I have the California version of the rule. California is one of those states. By the way, this is separate from what many health plans also require providers to sign an attestation in using telehealth. And so, so that there's a difference. You pay attention to whether the plan has an attestation that you need to complete, and then whether a consent is required. And I have a map here. These are the states. The states in light blue are the states that are still consent states. There's some variations. Texas and Washington are states that require a patient written acknowledgement. And then the 30 states that do not require additional consent. This might be slightly...
Harry, really quickly, the link that you said to look up, was that the CCHPCA? Is that correct?
You know what, if you, Sarah, I know it's on your website, if you can...
Yeah, I'm linking it. I just want to confirm that's the correct one.
Yeah.
Great.
Exactly. Thank you.
That's different. Okay.
I misspoke before. Sorry about this. Yeah, thank you. All right. So this is what I want to say about just telehealth consent is I'm an advocate for, irrespective of whether you're in a state that technically requires it. The states that did away with the requirement did so because, you know, it was seen as sort of somehow treating telehealth as less than or a different kind of treatment. But I actually think it's useful to, along the lines of the comment that I made earlier, that telehealth requires a more engaged, more cooperative, more active patient. I'm an advocate for a global use of informed consent. By the way, one of the things that you want to do at the same time that you get informed consent is get an authorization for new kinds of data exchange, right? For example, in many cases, you may want to not only document a telehealth encounter, but actually record it. And that's something that patients should consent to. There are also issues that should be flagged for patients, right? Is there going to be sufficient quality in the interaction across a platform? We as human beings depend so much on nonverbal communication that a particular provider, a particular patient may have an issue with telehealth. There may be problems in the transmission and communication, right? A disruption, and I'll talk about a little more about that. But those are issues to talk about, right? The difference of not having in-person support, and of course the risks of data breaches. For all these reasons, I'm an advocate for using informed consent, not just having a form on it, but actually having a conversation that gets documented in the record. I talked already about the licensure issue a little bit. By the way, very interesting, on March 19th, Health and Human Services and Medicare suspended out-of-state physician licensing restrictions. We have not seen this for any other health profession, but so for physicians who are working on providing necessary care, based at a federal level, practicing out-of-state doesn't matter. Let me give you I want to make sure people come away from this webinar with the essential rule that you need to know, which is that generally, wherever the patient is located is the place of treatment where the provider needs to meet licensing rules. That's the rule, right? So sometimes we're seeing a slow trend towards more states liberalizing and allowing practice across state. For example, the state of Florida allowed physicians to they've created a mechanism for physicians not licensed in Florida who are only doing remote telehealth in Florida to provide services there with a much simpler, streamlined approach. So we're seeing this go away, but in general, the important rule to take away here is that providers need to be licensed where the patient is, at the distance site, either where the patient lives or if for some reason the patient is temporarily away from their residence. But that's the critical location, and we don't have any relaxation among all the changes that have happened. We haven't seen any liberalization on the licensing, state-by-state licensing for other kinds of providers. So my argument would be careful to respect those limits of where you are licensed, where your organization and where your professionals are licensed to treat people. In the past, we've seen this is another one of these historic telehealth differences that has slowly faded away. We've seen in-person encounters to establish a relationship being required, saying that you couldn't start a new relationship online directly in a telehealth encounter. That has largely gone away, and it is certainly I do not see it as an issue in the crisis. And I also want to say here that in some cases, providers are in favor of a partial in-person, partial telehealth relationship. I spoke to a provider who was conducting urine drug testing, for example, in person if they couldn't use remote, labs, and then doing all counseling by telehealth. So I think that all states that allow for telehealth also allow for some kind of mixed service delivery. Of course, it will have to be documented, which we can talk about. So documentation. There are some things that need to be documented ahead of the encounter that are important to keep in mind. There's a lot of information that we take for granted is going to be covered in an in-person setting, but needs to be spelled out much more carefully in the telehealth encounter. So one of those is identifying who is the provider, right? If the provider and patient aren't in the same room, the provider should document who they are, provide their credentials, the name of the client should be verified. There's a lot more, the way to think about these issues is that the plans who are going to be paying for these services when they're billed want to verify exactly who was involved in the particular encounter. It becomes very important to document the site, particularly the originating site. I recommend as a best practice documenting the distant site. In some cases, we have providers who don't want to include their home address, and that you can certainly just note that the professional was at their home without putting the specific address if that's an issue. But the originating site must absolutely be located, maybe mentioned, and some description of the professional's location should be included. Important to include contact information for the professional and the client. And here I want to stress, if there's a risk of disruption on the call, which is always the case on digital communications, there should be some communication of how contact's going to be restored. We're seeing, by the way, in the general rule is that client financial responsibility is copays, coinsurance, and so on, deductibles are the same with telehealth, although we are seeing a number of health plans, major health plans, waive copays simply in the name of facilitating more telehealth in this time. In general, the standards for documentation are the same for in-person care as they are for telehealth. The difference that I mentioned a minute ago that I really want to stress is that there's a lot of additional communication that happens in telehealth. Electronic communication, emails to set up and give instructions on how it's going to be done, informed consents, potentially recordings, which are a valuable way of proving what you actually did. It's important to make sure that you get authorization for the patient for that, and let patients know. Patients should know that if you're going to be recording, which is from a reimbursement standpoint, is a best practice. In terms of the technical platform, we talked a little bit about this already. Historically, there's been a strong emphasis on it being a HIPAA compliant platform that protects privacy and data security. Now, as we've seen, it seems that through this crisis, we're in a much more liberal period. The key things I would encourage people to focus on are talk to your patients, have a backup plan, have a phone number so that that everybody knows what's going to happen if an encounter is disrupted, how to get it started. As a last resort, there is phone, although that is an issue for some payers on payment. Make sure you have decent connectivity for uninterrupted communication. And then I've had questions come up about what do you do if the family doesn't have hardware or connectivity. Certainly, it should not be marketed to patients that particular providers are offering these things. That would be potentially an inducement. But if you are in a situation where a family or a patient needs connectivity or hardware, we are seeing some providers beginning to do those things. If they're done on a limited and discrete basis without being promoted to drive patient business, I think that they are a safe activity. A couple other things this is a concept word to understand where we are as a country on telehealth is parity. Parity has two different meanings in the telehealth context. Parity can mean that can the service be provided, and parity can mean, am I going to get paid the same thing as an in-person encounter? So in terms of services parity, this is a California requirement, but it is representative, and I'll show you a map of where we are on parity of what many states have done. Essentially, the payers have said the state laws have said that health plans may not limit providers to only provide care in person. They can't prevent this. They can't limit particular settings as not being appropriate for telehealth. Services that are appropriately available through telehealth in terms of standard of care have to be allowed to be delivered under member plan contracts and plan provider contracts. That has not been adopted across the country, but that's what we talk about when we talk about services parity. The bigger issue is rate parity. And we've seen, by the way, in this crisis, many plans have come out and said they are going to have rate parity, and they are going to pay the same amounts in the crisis for telehealth services as they would have paid for in-person. But just to give you an example, this is California's law, passed in the fall of 2019, and it provided that effective January 21, all plan contracts must pay providers, this was not specialty specific, for diagnosis, consultation, or treatment by telehealth on the same basis and to the same extent as in-person care. It didn't stop plans and providers from negotiating different rates, but this law has some provisions that are not delayed until January 21. So there is in California and in a handful of other states some restrictions on a requirement that services that are the same, whether it's in telehealth or in person, be reimbursed at the same level. We are in a slow move towards parity. This is a law that this is a map that shows it, although it doesn't distinguish between rate services and rate parity and service parity. But what you see is that the general trend is towards parity, and I think we're going to see. I think one of the outgrowths of this crisis will be a push for more and more parity. So just highlights again. I'm using California as an example, as a model, and it's important to check your state. But in California, this is very important. There's no requirement that plans must cover out of network unless it specifically says so in the law. And California is not a state, and I'm not aware at the time of this webinar of any state that requires a health plan to cover out of network. So in the crisis, there is coverage, but this is a long-term issue. So this is really a place where having a contract with the health plan is critical. And we are seeing that under contract plans are paying for behavioral health telehealth. No requirement that telehealth reimbursement be unbundled from other capitated or bundled risk-based services. That's also California specific. And some parity also on copay and co-insurance. All right, I wanted to, as a final topic today, talk about reimbursement. The big issues I would encourage people to think about are, and again, we're seeing if you have assurances from the plans, then you don't need to worry about these, but the issues that you should generally be thinking about are, does the plan this particular plan that I'm providing care under does it include a telehealth benefit? That's a big question. Ordinarily, in the crisis, at this moment, there's incredible liberalization. Another big issue, I just mentioned out of network, right? Out of network ordinarily would be a problem for telehealth services. In the crisis, we are seeing a difference. And finally, can you meet all the requirements of the services necessary in the case of services that are bundled? And I'm referring there specifically to things like urine drug testing. So what are the common problems that we're expecting to see from the payers? By the way, I want to say, I've spoken to a number of senior people in leadership roles at different payers, and I think that there is a spirit of good faith that I'm seeing in the moment from payers. But when I put this out, I think the reality is that payers are going to be inundated with claims. There's going to be some processing errors, just as many providers will make errors. There will be many, many payer processing errors. And I do think there is that fraud and abuse concern that I mentioned. But the main issues why telehealth claims are not going to be paid is the number one issue I expect is lack of authorization. So it's very important to speak to the plan and try to get authorization if you can. The second biggest reason is, and I'll talk about this is for professional CPT codes rather than revenue codes, is the place of service not being mapped to the authorization. I'll talk specifically on the next slide about that, and it'll make more sense. Likewise, about the lack of use of modifier codes. I do think that providers should be prepared for enormous payer processing errors, for internal confusion over the requirements, and be ready for appeals. I am concerned about issues with out-of-network claims and issues around coordination of benefits. What I would say is that you should be doing as much checking of plan requirements and updating plan requirements. I know it's not easy to talk to the payers. The payers are overwhelmed, although I am seeing some really good information being put out by many, many payers. I think it's important to stay on top of that and then trying to build communication with payers and building a denial management process if claims are getting denied. So I want to talk about modifiers. There's enormous confusion about this. So when we talk about CPT codes, professional codes that get billed on a CMS 1500 form, in the professional service context, there are generally two important codes that are relevant. And I put up the CMS 1500 form to show where those go. On line 24, when you put in the service date, you can put in under place B, the place of service. So the place of service that you should use for telehealth on that form is O2. That is the modifier code that indicates that the services were provided by telehealth from a distant site with the provider at a different location. And then likewise on part D, under the modifier for unusual circumstances, 95 is the code that signifies that it was a synchronous telehealth service rendered by real-time interactive audio and video. I want to note on the left side I put here that there are specific older codes that were actually retired by Medicare. There's a code GT. Some health plans are still using that code, and if your plan wants you to use it, instead of 95, they want you to use GT, then if the plan tells you to use it, I would say use it. But that's, those are the modifier codes. Now, here's where a lot of the confusion comes up. If you are an outpatient program or an inpatient residential facility, you don't use this as CMS 1500, right? You're billing under revenue codes on a completely different form, and there are no modifiers for those forms. Unless the plan has given you something specific that they want you to do, the appropriate way for outpatient and inpatient services to note that there was telehealth used in the delivery is to actually put it into the record itself, so that that can be identified by the plan in reviewing the code. There are no modifiers for outpatient programs. So that's a point of confusion. I also just want to point out, I took here an example from Magellan. I included the website if you want to see this particular example. In the professional services context, there are a lot of guidances being provided of how they want modifiers to be used. I note, for example, Magellan is encouraging people to use GT, even though it's no longer, it's been retired by as of last year, or 95. But we're seeing that they have specific codes also at the very bottom, you'll notice, for inpatient telehealth. So if you're doing stuff, if you're inpatient and you're doing telehealth, those are important codes to, at the bottom of this page, to be paying attention to. All right, so I want to have time for some questions, and I just wanted to, just as a final thought, I know this was very quick, there's a lot of information here. I hope it was useful. I do think we're in an environment where things are moving quickly, and as things change, we'll be glad to share more information, but I want to just try to get a message out there as broadly as possible, that there's an incredible opening that we've seen towards telehealth in the behavioral health context. The only caveat is that many of the changes are short-term through the emergency period, and there's still significant work that needs to happen for long-term use of telehealth. So study the payer guidelines, be in touch with your payer contacts, and we'll be providing more information to come. So with that, I'm going to turn it back to Sarah.
That was fantastic, much appreciated, and we're getting some great feedback in the chat. A couple questions. Yes, we will be emailing the presentation. Yes, we will record it. Yes, you will get a copy of this. Can you confirm, Harry, no modifier for UB04?
That's correct. I have spoken to multiple plans that have no modifiers for UB4. The description should be in the text of should be on the claim form itself. It should be clear, but otherwise it is a yeah, that's yeah. Perfect.
We can still see your screen. So and then the other piece is what types of health professionals or credentials are able to practice with telehealth?
So again, as I said earlier, it's a state-by-state issue. You have to always, the answer to that question is always going to be by reference to what does that state provide, who's allowed to provide telehealth. And so what we've seen is that sometimes I'll give you an example. The plans, what we found is that, just to use a California specific example, in California, there are no limits on who's allowed to deliver outpatient programs. So when it comes to delivering an outpatient program, sometimes plans will say, well, you don't have the certification, which is for substance programs that's optional, and providers have the better half of the argument to say to plans, you can't force us. We're allowed to run without a voluntary certification. We're allowed to provide outpatient services. We're authorized by the state to do so. the providers will say, well, you need accreditation, but the providers have the stronger legal argument in that context, even if it's simpler just not to argue with the plans. But in this context, the critical question is, what does the state law say about who's allowed to provide telehealth in your state? So California is a state that has made a few exceptions. There's an exception in the telehealth law for autism providers, but it's very clear that in California, for example, any licensed health professional, it doesn't matter whether you're a MFT, an LCSW, it's not limited in any way to physicians, can provide care, but it's ambiguous whether a certified counselor, is fully authorized to provide the service by telehealth. So in this crisis, there's been a complete authorization of telehealth services that we've seen from most plans and from some states. But I think in the long term, that's an issue that you need to look at on a state-by-state level.
And then there's just a couple questions about HIPAA compliance software. Just a reminder, the OCR is not enforcing HIPAA. You will need to monitor that as it changes, but any questions about whether certain platforms are acceptable right now, it appears like anything goes. So I'm going to skip over.
I will say some of the comments I've heard in terms of thinking about the security of the platform. It should be clear who's actually, you want to be monitoring exactly who's in the platform. There should be some way for whoever's facilitating to remove people from if they're not authorized or intended to be included in the encounter. So as long as it's a platform that has some reasonable level of security function in that sense, it should be okay. We're seeing really a broad acceptance of the mainstream platforms.
Do you recommend separate claims for in-person versus telehealth?
Sorry, I didn't understand the question.
Do you recommend separate claims for in-person versus telehealth services?
I would bifurcate. Yeah, every claim should be bifurcated and separated out. I've had this, but there should be, you want to separate out as much as possible.
And then there's some confusion about how do you register the patient, or like how do they sign in and sign out? So how do you kind of document the time spent with them?
So again, I'm an advocate of recording, in addition to having some documentation before, is having, if you actually get approval from the patient and save the recordings of the encounters, then that's the best documentation you can ever have. If you don't have that, you could theoretically, you could just record it manually, but the safest way to do it, in my opinion, is, if possible, to actually save the recording itself.
How do you feel about telephone when it's not covered and charging cash? Do you think that that's a viable option?
So historically, I'll just share with you, I've been providing telehealth service advice on telehealth services for 20 years. And that was a big issue that people got in trouble for in some states. California was one of those states that had a real resistance to any health service just being pure telephone. There were some states that were more liberal on it. So historically, there's been a concern that you can't get enough information to truly assess the patient, do an examination by telephone, and that was a dangerous place where, frankly, like where we would frequently see the medical board or other licensing boards take action. In the midst of this crisis, my opinion is that there is no licensing risk as long as what's being done by telephone is being done in good faith and responsibly. I believe that there is a latitude to pretty much do any service that you can do in good faith through the telephone if you don't care about getting paid. I do think that that still is a very much a live issue, and if you pay attention to what's going on in some of the major cash pay commercial website sites, you see big fights still ahead, but those are sort of suspended for this crisis.
And can you confirm that telehealth can be used for groups as well as individual sessions?
Absolutely. So first of all, there are a number of programs that have been doing an outstanding job with outpatient group counseling on a Zoom type platform where everybody can see everybody else. And that's been going on for some time, and it's totally appropriate. So as long as you can run a group where people can do the fundamental thing they need to do in groups, which is talk to each other across the group and visualize and see people across the group, it's totally appropriate way to conduct an outpatient.
How are residential treatment centers currently addressing safer at home and 6-foot advisements? Are they still operational? How to facilitate in a group environment? And I'm just going to jump in and say, my understanding is the 6-foot advisement does not apply to essential services, but correct me if I'm wrong, Harry.
I think, look, what I'm seeing is organizations are putting policies and procedures into place to try to maximize distancing. You know, I'll just give you some examples of some of the big things we're seeing. Number one is daily logging of temperature and symptoms for both patients and staff. We're seeing a lot of facilities quarantine some staff so that not everybody is potentially exposed if there is an issue, and there are people available for a backup. We're seeing that there's efforts to stagger any kind of gatherings to try to meet 6 to 8 foot spacing guidelines for meals, for groups, for any kind of necessary travel. You know, there's a big effort underway to try to space people out, and then different states are coming out with different guidelines. So here in California, for example, there were very specific guidelines put out by the Department of Healthcare Services on what to do if you have somebody who's had a point of exposure. You know, in general, if somebody can't be taken to a place where they can be safely isolated and they are going to stay on site, you know, having them wear a mask. You know, there's very specific isolation protocols. But so there definitely are a lot of steps to take to ensure maximal hygiene and safety in residential settings during this time. But we're finding many facilities are actually having a rising level of capacity, you know, out of demands, some sort of behavioral health challenges driven by this crisis.
Great. Some questions are relating to like the assessment intake process, and some questions are whether you can use DocuSign type services for intake paperwork. My understanding is yes, you can. Just make sure that it's HIPAA compliant as you continue.
Yeah, so let me just say this about DocuSign. First, DocuSign is in I believe in every single state. DocuSign is recognized legally as equivalent of signature. There are a lot of traditionalists. I have some partners who are older than me who still question whether a DocuSign is just as good, but there's a law in every state that says it is. Historically, you know, we had issues with insurance companies not liking things like, before we had DocuSign, we had signature file stamps. Maybe I'm dating myself by remembering that, but basically insurance companies did not like that, and they always wanted a wet, fresh signature. But in this context, DocuSign is totally appropriate and reliable.
Right. And I was going to say too that just a reminder that if you want templates, there's a lot of questions about policies. If you want templates for consent and things like that, I just put the link for the joining as a member. And we have a number of templates for under the telehealth tab, if that's helpful to you.
And we're going to be coming out with, we're trying to come out with more resources in the coming weeks just to address all of these, in the coming days to address these issues. So yeah, and you have great resources available also.
Great. Let's see. There's some questions about working with minors. If you were working in the school with counseling, if you have any suggestions for that.
So, I mean, we're seeing in most parts of the United States, obviously schools have been shut down and have moved to remote services. So I'm not sure I understand the question, but I would also, everything that we've said about remote service delivery with minors would apply here. Would apply. We are seeing, by the way, the previous webinar was really about the autism and ABA space, but we are seeing still some resistance to like direct therapy with in that context, but in like the more mental health adolescent space, for example, everything that we've said today, I think is fully applicable in terms of converting even school-based services to remote audio, video, live synchronous telehealth.
Great. Okay, we're right here up on the hour, so I wanted to thank Harry for that wealth of information. I know that a lot of folks need it right about now. There's a couple of questions that we didn't get to, but Harry's contact information is there, and I'm sure that he would be happy to assist. Again, he's just a true resource in this space. So thank you all for spending your morning or afternoon with him. And if you have any questions, we hope that you find your answers, and best of luck to everyone. Stay healthy.
Thank you so much.